stop going straight to the injury. Well, let me see how many degrees of motion. Degrees of motion are irrelevant. Hi, everyone. Welcome back to the podcast. Welcome back to any new listeners. Welcome to a podcast that hopefully gets you thinking a little differently, a little outside the box. For those of you who are coming back, welcome back. Today's podcast is about bone injuries, and there's going to be a wide gamut that we're going to review today. But I wanted to talk about rehab timelines and guidelines and things that I've seen and a couple different scenarios. So before I do that, let's get back into just what's new in life. I took a couple days off, and I'm back from just a rejuvenation weekend with the family, and we went back to the great state of Ohio. And for those of you who don't know, I did my sports residency at The Ohio State University, met the woman of my dreams, my wife, and we moved back to San Diego. And so we enjoy going back to Ohio. And it is it's very humbling to go back to Ohio. I love it's like the country is acres of land, and it's great to just be back with really good people. My wife's family is amazing. So, yeah, just rejuvenated and excited to be back. So, why am I doing this podcast? So, we had a team meeting, and all of my podcasts are really about what's happening in the week and what's happening with the team, and what are the trends that I'm seeing, both from clients' perspective or cases or tough cases or phone calls or just team members having questions. And this one is bone injuries this week. We reviewed a couple cases, and I thought it'd be great because they're unique cases, but then I think the principles are actually, they apply to everybody. So I hope they help. All right. So when it comes to bone injuries, some of the cases that we see here at Sports Performance are very unique. They're people who have maybe tried other places. They've done chiro, PT, massage, an ortho, a neuro, a podiatrist, orthotics. They've done the whole gamut. And they're looking for something different. They're looking for, like, not necessarily last resort, but they're trying to figure out where the root of the problem is. And we see a wide variety of ages. We have as young as 9-year-olds to 18-year-old in college. I mean, you name it. So we recently had some bone injuries of the foot with young dancers. So and then we recently have one that is a little older that is not healing as well, and they are looking to go semi-pro basketball. So a couple different scenarios, and when we reviewed it, we realized that the principles were the same. That the problem became the injury site was different, so it kind of changed the way we saw it, but ultimately it's the same. So the unique part about seeing people direct access, or seeing them before they see an ortho or whatever it may be, that's tough. I as a profession, I think that we ultimately want to be there. We want direct access in every single state, to be able to see anybody we want anytime. But there's pressure involved in that. There are cases that maybe you don't see as often, and what that does is it puts you in a tough spot where you have to be really good at your diagnostics. But it's really hard to be good at diagnostics if you haven't seen these cases before. And so I was talking to a team member yesterday, and I said, one of the greatest parts of working in pro sports in my residency was doing these grand rounds, or just doing rounds with primary care sports medicine, primary care physicians, and then orthos as well. So just shadowing them for a year and a half, and just like watching them and seeing enough cases that came through that you were like, oh wow, you see trends. Like, how did you manage that? Why did you decide to do that? How come you just gave them meds and told them to take 2 weeks off? Why didn't you tell them this? Why didn't you send them to neuro? Why didn't you send them to ortho? Why didn't you send them to PT? So having those great discussions, and then working in pro sports, I've mentioned that working in pro sports, you kind of work in a campus. Imagine a stadium, or a team, or athletic training room, or in the Olympic Training Center. It's like a campus. So you're seeing people every day, and those problems that arise every day are a little different. Everything from wound care to bone injuries to ear infections. I mean, you see it, and it's crazy because it's very tough otherwise to have access to that. And when you get musculoskeletal conditions that are acute, yes, we can manage an ankle sprain. Yes, we can manage some shoulder pain. Yes, we can manage some back pain. However, when you get bone injuries that are acute, semi-acute, sometimes you wish you had access to an MRI or a CT scan or an X-ray, whatever it may be. And have to ask, how does that change? Because this is one of the cases that we talked about yesterday. How does having imaging help you make that next determinant? And it does. It has its place. And I want to share that with you because if you work in an orthopedic clinic where you're seeing people typically 4 to 6 weeks out after an injury because they have to go through the whole process of insurance to, get authorization, or maybe they even got fast, you're seeing them within the first 2 weeks. Good for you. So I think that um, the type of person that you see, the type of injuries that you see will be very different based on where you work. So I'm going to go through the whole gamut and talk about a couple cases that I think that really can help you with just your overall rehab process and the way you approach people. Okay. No, I'm not going to go into the like the nuances of like how to treat and which exercises, because in my personal opinion, I think the exercise is not irrelevant, but it is tailored to whatever you want. That's not none of my business. I think there's different exercises that are going to work better than others, but overall, I think creating the framework is probably going to be your most bang for your buck. If you approach and program for somebody, it'll be more efficient than deciding on the exercises at the wrong time. And here's why. All right. So when we talk about a bone injury, let's talk about one case we had yesterday was shin splints, like true MTSS. So distal 1/3 tender, as and so this person's a basketball player, and they had a 6-week history leading up to developing the pain. So it started getting achy. No new shoes, no increase in basketball. 22-year-old, and they enjoyed playing basketball. However, the volume and frequency or intensity started to generally increase. No real change in shoe wear, and the goal is to get to semi-pro basketball. So they enjoy playing probably 3 to 5 days a week, and the injury was progressing. And so now we have to decide when they come in, what's the goal? So before we talk about the exact exercise or the exact things that they needed to do or evaluate or whatever it is, I think you have to work backwards. So if somebody presents to you, the first thing we got to do is what's the goal? Tell me so I can set this framework. And I think that that's where we as PTs don't do the best job. We're really like, okay, well, let's fix it. No, hold on. Before we even talk about anything, we asked, okay, what's the goal? Okay, I want to go to semi-pro basketball. By when? As soon as possible. No, by when? I need to lock in a date. Like what's anticipated? Whether you're working with an agent or you have something to qualify for. What is it? They said they really want to get in conditioning, and they have up to 3 months. All right, so let's go 3 months. Perfect. All right. If 3 months is a case, and they want to depart, and they have to be in peak physical condition, let's give them a month. So we got 2 months to get this person better. And then from there, we have to figure out how is this realistic? So if we're seeing them 6 weeks after injury, we have 2 more months to decide whether they can go or not. But that's 6 weeks from injury. Now we haven't started any recovery process. So if you imagine that bone is irritated at 6 weeks, what would you do? So obviously we want to remove the stress. Are you going to allow them to play basketball? Ideal world, no. And it's a hard conversation. How can we maintain conditioning? So we're going to have to be creative here. So we just can't do impact activities. So the distal 1/3 of the tibia is inflamed, tenderness palpation, positive tuning fork, and no previous x-ray, no imaging, and no previous treatment. So what do? Ultimately, we have to get ourselves 6 to 8 weeks to figure out how intense of a bone injury this is. So from here, they haven't gone to primary care. They don't want to. They're not concerned about imaging. They just want to get better. That's perfect. That's up our wheelhouse. And then you have to kind of set those bumpers. And what I mean by bumpers is you always have to have plan A, B, and C. If plan A doesn't work, where are you going? Because you need to tell them that. And just gently let them know what options are. Because if your plan A doesn't work, they're going to think that you're incompetent. You don't know what you're doing. And you're like, whoa. No, it's not that I don't know what I'm doing. I just know that there's an ideal, there's less than ideal, and then it's like, uh-oh, what are we doing just in case? And I think you have to have that. So on the initial evaluation or initial visit, we're planning out the first 6 to 8 weeks to allow that bone to heal, so no impact. The feet can't leave the ground. We'll do all the treatment. We'll do whatever you believe in: massage, eccentrics, stability, single leg balance, whatever it is. So now let's go external variables. So let's go shoe wear. So let's modify some shoe wear. If you're an orthotics person, great, no problem, orthotics. If you are a just rest it, perfect, and that sounds great too. You have to, okay, so where's the stimulus? Where is this coming from? So if we're assuming this is, posterior tib and it is irritated and it's causing the problem, so we have to fix the underlying problem. Is it a hindfoot problem? Is it a midfoot problem? Is it a strength problem? Is it a balance problem? Great. Do all those things, but where's the framework? Okay, so at 6 to 8 weeks, we're hoping that it is 90% better to return to sport. That's a marker that we use here personally at Sports Performance, and it's something that has worked. And you can have all the objective measures, as many as you want, but ultimately, if they don't feel prepared to return to sports, like having an ACL, 9 months out, and you're like, oh my gosh, you did all your testing, your single leg balance hops, your triple leg hops, all these things are in line, and you're at 95% within each leg, and they're like, I'm only like 80%. Then the 80% trumps your single leg balance or your hop testing or anything else, because the subjective report will influence their ability and their confidence going back, and that's a big deal. So I need 90% subjective report. I need, no tenderness of palpation, no pain with ADLs to be able to advance to that next level of plyos and everything else. So if they're not at 90% after 6 to 8 weeks, this became the question. What do you do? What are you doing with this person? And it's pretty straightforward. That plan was set from the beginning that if you didn't hit 6 to 8 weeks, 90%, you're going out to at least 10 to 12 weeks and allow full bone healing. Yeah, we understand that 8 weeks would be great. That's a pretty standard bone healing process. But if you can't get them to 90% and you haven't been able to shut them down, or like at this point, you have to be more aggressive with that. So you can talk about a boot. You can talk about, truly, do you need imaging at this point? And for most people through insurance, it might take 3 to 4 weeks anyways to get approval. So I think that ultimately around that 6 to 8 week mark, we start having a discussion of, hey, we talked about plan B. If it's not 90%, we're going to go a little bit more aggressive and give you a boot. And then we'll completely rest you from all plyo activities, feet leaving the ground. You have to be 100% diligent with it. And if they want a little bit more, you have to determine why do people want imaging? Is it, for most people, it's peace of mind and knowing the direction that they're going is the proper way. And I think that's fair. And I think that if you were injured, you might want one. So have that discussion with people. And I think that's very fair if their primary care is on talking about it. I think that you need to help support them and understand there are different directions you can go. And nowadays with internet, people can pay for whatever they want. We have an out-of-network company that we work with that does X-rays and MRIs and CT scans and orthos to be able to help do a basic evaluation. Here's the case, and if you want an MRI, we'll get you one. That's not a problem. And what that allows them to do is have power over their own health. And that's massive. And I think we all fight for that, right? That's why we want direct access. That's why we want to get people healthy, and we want to work on injury prevention. We want to do wellness care. It's the same thing. So allowing them to have those opportunities and talking to those people and getting in your community and seeing if there's what resources you have. So at 8 weeks, if they're not great, start thinking about much more conservative care. A boot, shutting them down completely, but understanding that they're going to lose fitness and then they're going to lose mental strength in this whole process. So I think what you need to do is you have to be stronger about communicating that with your patients and clients, and understanding that you need to have a plan A and a plan B and a plan C. And a plan C would be truly imaging and shutting them down completely. Plan B would be, okay, well, let's talk about being in shoes 100% of the time, in a boot, 4 straight weeks, whatever it is. So you just have stricter guidelines. At first, you might say, okay, let's just try exercise and no plyos. And then you're like, well, that didn't get you better by 6 to 8 weeks. You're not 90%. You're still tenderness of palpation. Well, let's lock you into a shoe all waking hours, or even after that, 2 more weeks. Let's get you in the boot all waking hours. And after that, we're going to get you imaging. And that progression allows people to understand that it's not that you're not getting them their outcomes, it's their foot is not responding to this care. And it's a sequence of events that need to happen in order for you to get to that point. But you don't want to throw that in from the beginning. Some people might want the imaging from the beginning. Cool, great. Now, let's have that discussion. What does imaging help you do? Imaging helps confirm, right? It gives that person that knowledge, assuming that there's not, even more incidental findings, and that doesn't throw them off for a loop, and they don't think their leg is broken and all these other things by the complicated medical terms. But what it does to the provider is it helps with your plan of care. So it just dictates the amount of time that it's going to take for this person to truly heal. So maybe you knew all along this was a bone injury, truly bone, not just like the lining. I'm talking about the actual bone. And what this does allows you to do is say, you know what? We knew it all along. Now you're having a shutdown completely. But for some, if they're young and it's not like significantly tender to palpation, it's not limiting their like daily activities, you question whether they need it or not. But if it's somebody who like can't walk, it's been dull, achy, it's like they got that boring, dull feeling, and they have a competition coming up, this might give them that little edge to say, you know what, it's not even worth it. You need to know what's happening underneath everything. So you take it case by case. So from a rehab perspective, on a bone injury, on a posterior tibialis irritation to an MTSS, I'm going to say it's going to take them about 6 to 8 weeks to get that 90% if you do it properly. Meaning, you can do the balance, strength, everything else, but you have to remove the outside factors. So make sure that they drop their plyos. They're not doing that. They're in shoes all waking hours. Let them know if this is not working, we're going to a boot. If that boot doesn't work, I highly recommend that you start thinking about some imaging. And if it continues to be a problem, you're going to have to keep them in there for longer. But I think partnering with the primary care or their ortho or their podiatrist, there's nothing wrong with that. And I don't think that that's a failure in anybody's part. I think working with other people who can view things a little differently is great, and it is a important asset in your professional growth. I have a team of people here in San Diego that I work with, whether it's podiatrists or orthos or primary cares, and I really think that it works better in partnership when you have people who are specialists in different factors. Like your PTs in general, somebody called and asked, hey, do we have a specialist for running? I think PTs, we're really good generalists, and you might have an interest and you might say like, I love running athletes. I think ultimately as a whole we know a little bit about different things, and then there's truly like specialists within each domain. And I love that. I love being almost like primary care for PT, in terms of musculoskeletal system. I do love my hip pain, SIJ pain, and low back pain. If you've heard my podcast, like I love them. They're my passion. But I wouldn't call myself a specialist. I'd say I can see the roadmap of where people need to be, and then I can insert whatever programming needs to go in there, and then you can figure out the exercises in between. So with bone injuries, it's the same process. So the second case that we had was a youth dancer with, I think, a second metatarsal fracture or at the MTP. Nonetheless, this athlete is pretty involved. They're high level. I think they practice like 5 to 6 hours a day, and it's I think it's different types of dance. I'm not sure if it's true ballet or other types. I don't want to mess up the case, but ultimately we talked about how long will this take. Now we have a different factor. If you've heard me say this before, they have youth juice. They're younger. Their healing times are a little faster, but you treat them the same. Now I would still present the same guidelines and let them know that if it's going to take 8 weeks, and this person's working with their pediatrician, and that's great, because I think you have to have a partner in this, in that you have to have the imaging, you have to have they know the case, they probably have blood work on them, they have their whole history, and I think that's a factor. Like, don't ever think that musculoskeletal care is the body region itself. I think there's an underlying case. It's like solving a case in a court of law. Like, what you just had was the accident or the trauma, but what you don't know is the whole story. And having a pediatrician was great behind the scenes. So making sure that blood work and everything else is good, there's not a bone density problem. This person was having pain. It wasn't resolving. They went in and got, I'm not sure if it was a true CT scan or a x-ray to confirm it, but it was confirmed it was a fracture. And so that was 70% healed. Great. So in this case, we have imaging now helping us set the plan. So if we know it's 70%, this person is shut down from practice. We are then going to use 90% plus a clear imaging that there is no more fracture, and 90% to return to sport. So now in this case, all you're doing is using that time to strengthen, balance, mitigate the possibility of it coming back. So most of the time we have imaging to help set the tone, but if you don't have imaging, you have to be able to create those plans, a plan A, a plan B, and a plan C. So my point to this is that bone injuries are complicated and they're going to be varying by different regions. I totally understand that. However, they're the same. 6 to 8 weeks, 10 to 12 if it's a bad irritation and they haven't been able to shut down. But if you can shut them down, you're looking at 6 to 8 weeks. In that time, fill it with whatever spices and whatever you want to do in terms of exercise and everything else. I don't care. I think that all that's going to work. Just don't mess it up. Don't control the outside variables and don't mess it up for those 8 weeks. Get them to 90% and they're going to get there. If they're not at 90%, you're bumping out another 4 weeks. Why? Because of the tissue healing. What's happening is they either have poor healing, something, whether it's a dietary thing or a hereditary thing, or you're just missing something on the background. I had somebody say that they think they had a base of the fifth metatarsal irritation. How about that? No trauma, no ankle sprain, no nothing. They started to hike more, and they said, "Hey, I'm going out of town this weekend. What do I do?" And I'm going to go hiking. Sorry, that's the part of the story. I'm going to go hiking for miles with a backpack on, and I now have this thing that's irritated. It's been a month, and what do I do? Oh, that's a different story because you have an event coming up. Now it's about tolerating. So now we have 5 days out from departure on a long trek, and they have a base of the fifth irritation. What do? You ready? You buy a boot, force them in it, all waking hours, reduce how much they're walking. At 5 days, they're not gonna reduce their conditioning in 5 days. It's already been built, especially if they've built it based on a program. So boot them. If they're okay with meds or an anti-inflammatory, if that's your thing, go for it. I would ice every other hour, lock that thing in. I'd be in no bare feet. You can use tape for support. Try all different types of taping, whether that's compression. Most of these individuals like compression, so I'll do like a light kinesio tape or something that gives them a little bit of compression. You can try a lift to the base of the fifth and then wrap, but ultimately you're trying to provide external variables. If you're a provider and you're about to see in 5 days, the natural instinct is to like work on it and start stretching it, mobilizing it. You're gonna flare it up. You are gonna flare this thing up. I have a passion for pre-event rehab or like treatment because it is an art. If you've been at a large scale event, we're talking like Super Bowl, we're talking about pro tennis, the Olympics, World Cup, something massive. Some of the best clinicians at those events a couple days prior, you better believe they're in high stress. And I've been there. What happens, I've seen other clinicians mess it up. They come in and they're like, I'm going to be Superman. Let me work on your base of your fifth. I'm going to stretch it, mobilize it. I'm going to do this really cool laser thing. And they throw their whole kitchen sink and they end up flaring it up. And it's because those treatments might work in an orthopedic or sports setting where you have weeks before an event and you have room to do that. But when you're right before an event, don't do it. Don't mess it up. Don't touch it. Don't irritate it. Now, with this person who's 5 days out with a base of the fifth irritation, I would just do like light soft tissue, nothing aggressive. I'm talking like 25 to 50% pressure. I'm not gapping. Do not gap that thing. Don't mobilize too much. I'd work on the ankle. I'd work on the calf. I'd work on the knee, the hip, the lumbar spine. Adjust whatever it is that your flavor is. But I would not. It, just leave the site of injury alone. It's irritated, especially before an event. Don't do it. You're setting them up for failure. All why? Because you think that you can fix it. Don't do it. So from a bone healing standpoint, if you have a fresh, irritated bone injury right before an event, I wouldn't touch it. The direct site, I'd work on everything else around that might be putting pressure there. Talocrural joint, MTPs, get them more mobile. Tibial rotation, whatever your flavor is, but I wouldn't touch the site. So we've talked about three different cases here. One that was 6 weeks out, that is, they have an event in 3 months. One that was found early and got a x-ray, which helped us set the plan. This one did not have the x-ray. And then the last one was a base of the fifth irritation, 1 month out, seeing them for the first time, and they depart 5 days from now for a long trek. Now, they're all very different scenarios, but in an ideal world, you would have them for the 8 weeks to be able to manage them. But if that's not the case, this is the challenge with direct access and seeing people, you know, with from the streets, and they've never had anybody look at it. This is why it's an art, because all three cases are very different, and what you're trying to do is put yourself in a position of, okay, what's the story first before going to the injury? And that is the challenge, and that's where I tell you guys to change your frame of thought. Stop going straight to the injury. Well, let me see how many degrees of motion. Degrees of motion are irrelevant to somebody who departs in 5 days. What you're trying to do is set the tone so they don't mess themselves up, and so they can get as close to 90% before they leave. The degrees of motion just tell you how severe it is or what they can't tolerate. But ultimately, you're not answering their question. What can I do? We call them yellow. We call them red, yellow, and green lights. What can I do? Your do's and your don'ts. What can you do? Can you walk? Not in bare feet, not in sandals. You better be in shoes. In an ideal world, you're in a boot. Well, what can I do? You can't walk for long distances. Let's keep you off your feet, especially if you leave in 5 days. I'd rather have you propped up. Go for a swim. Do something. Tape their foot up. Don't let them go into plantar flexion inversion against the wall or pressure. Go for a swim. Go on a bike. Maybe go on a rower if that doesn't irritate it. But I put a bike on there and to change the seat height so they're not fully in plantar flexion inversion. You have to find a way just to maintain fitness. Upper body ergometer, I don't care. Do something. Okay, what can I do? What shouldn't I do? I wouldn't irritate it. Stop stretching it. Stop mobilizing it. I'd apply tape. Forget about it. Don't even look at your foot for the next 5 days. Should I do anti-inflammatories? That's up to you. That's that is a personal decision to make. So what you're trying to do is give people their bumpers, and giving them a balance exercise isn't going to help them because it's only going to irritate them. Mitigate how much stress is being applied to this person. Somebody who's 6 to 8 weeks out from a goal, you can start doing that stuff. That's not a problem, because you have a little wiggle room to flare them up if they're okay with that. They have a little time, so you have to figure out their case and what they can tolerate. Somebody 5 days out, nope, not happening. So three different cases, three different scenarios on what I would do with bone healing, and they're very unique to the setting that you're in and what you see coming into your facility. So whether you're in ortho or you're in sports, you might see these different type of cases, but nonetheless, the framework is the same. In an ideal world, I would have 8 weeks. And if it's not 90% by 8 weeks after you've controlled all the variables, you're going out another month. If that's not better, you might have to start considering imaging. And that's why it's great having a partner with pediatricians, primary cares, orthos, whatever it is. So there you have it. Bone injuries explained with a couple different scenarios, and I hope that you get to see these type of cases because they're amazing. They really challenge your framework. And if you have cases like this and you want me to review them, and you think that you just need help with a bird's eye view of what you're missing, send me an email, drchris@drchrisgarcia.com. I love these cases. I'll review them. I'll put them out to the world and tell you what I'm thinking from a logical, like, objective standpoint. What do we need to do? What are you missing? Why isn't this person healing? What do they need? What's part of the story that we're missing? Like this is part of the thrill of being a healthcare provider, and this is a part that I love, and I want you guys to love it too. All right, there you have it, and there's the podcast for the week. I hope you guys are doing incredible, staying active and healthy and loving life, just as I am. All right, guys, I'll see you guys on the next episode. Take care.